now we're really lucky to have Dr. Arlene Drack, who represents the center at University of Iowa, which is involved in the phase 3 studies. And she is a pediatric ophthalmologist and retinal degeneration specialist, had been practicing in Colorado for more than 20 years, and went specifically to Iowa because of the exciting work going on there. Thank you, Arlene.
Thank you, Jean. First, I just want to say I'm very honored to be participating in this session, so thank you for inviting me. The slides are not advancing. There we go. So one of the first lessons that we learned participating in these trials is that genotyping is of vital importance in gene therapy trials, and that may seem self-evident, but I still receive emails from patients and parents asking if their child is eligible for the gene therapy trial, but when I ask about their genotype, they haven't had genetic testing yet. So we still have to continue to educate people that gene therapy is really gene-specific, and each patient needs extremely careful genotyping. So what do we mean by extremely careful? Well, RPE65 LCA is autosomal recessive, so patients must have 2 disease-causing mutations found to be certain that this is the diagnosis. And we do 2 sample confirmations, meaning we take 2 samples from each patient and run them separately so we confirm it. And then we test parents of the patient for phase or segregation, because if they have 2 genes affected, they should have gotten 1 mutation from each parent. You can have 2 mutations on 1 gene and the other gene normal, and that means that RPE65 is not causing your disease. What about patients who are adopted or don't have living parents? We can still confirm that they have 2 mutations, 1 on each gene, but it takes a little more time, and we need some lead time to do that. So in a relatively small trial, if even 1 patient were to be enrolled who did not have RPE65 as the causative gene, it could significantly affect the findings and perhaps mask a treatment success that we wouldn't want to do. Here's an example of a patient, an 18-year-old female who has LCA. That's her fundus photo at the bottom, and she had genetic testing. And so one question would be, is she eligible for RPE65 gene therapy? She does have a mutation in RPE65, but it's heterozygous. And in fact, she has mutations in 2 other LCA genes. But in only 1 LCA gene does she have 2 mutations, 1 on each copy of the gene with confirmed segregation. So this is a patient with NMNAT1 LCA, not RPE65 LCA. So just finding a mutation in RPE65 doesn't mean the patient's eligible for the gene therapy trial. And we have found in our lab doing exome sequencing on patients with other types of retinal degenerations that about 10% will have a mutation in RPE65 or one of the other LCA genes. That doesn't mean they have LCA. So the genetic testing can be quite complex. Another lesson we learned that kids are quick to adapt to the new normal, and they may forget how they used to see, although their parents will remember. So a lot of them would come back, and I would say, well, what have you done differently? What's new? And they would kind of come up with a thing or two, but then their parents could list a lot of concrete examples of new activities that they could do. And also, the kids in the gene therapy trials have had a lot of questions about the specific procedure and if it would hurt. So I'm a pediatric ophthalmologist. I've done pediatric eye surgery for years, and we discuss the surgery, and kids will often have questions. But I've seen a new level, and maybe we'll hear from the Duays about this, and Yannick can tell us his experience. But I think because they go through so much testing and consent forms, and they see their parents going through all this, that they're really focused on it, and they will ask me, how are you putting the needle in? What are you doing? So I found it's really helpful to just keep telling the kids, you're going to be asleep when it happens, so don't worry about it. And I think that puts them at ease. This is a picture of one of our families before the first surgery, used with permission, but we've masked it for anonymity of the subject. But you can see the mom's thumb is up and the child's thumb is up, but maybe not quite as high. I think they've had a little trepidation, but the interesting thing is, because this is a 2-eye trial, the kids have been very eager for the second eye. They're a little bit concerned about the first eye. They want the second eye done, and that has said to me that we're really doing something helpful. So I think if we're going to use quality of life instruments, we really have to include parental input as well as the child's input, because it's like other pediatric ophthalmology surgeries, like congenital cataracts. The kids just kind of go to a new normal, and they see what they see, and the parents will need to tell us what has changed. Our lesson number 3 is, should we go for the gold or play it safe? And I hope I can get this to work. This is a video of one of our gene therapy surgeries. And Steve Russell is our retina surgeon who's doing these surgeries. And you can see the retinotomy was just made and the bleb is coming up. And at this point, I was saying to Steve, it's going toward the macula. Steve, it's going toward the macula. It's going to go under the fovea. And he was saying, well, you know, I don't have total control. And we're really having cognitive dissonance at this point of the surgery because both of us want it to go under the macula and under the fovea because we know that might give the best chance for good acuity or improved acuity. And both of us are afraid of the adverse events that Al McGuire so nicely reported of popping through the fovea and having a macular hole. Even though it has been self-sealing, that's not ideal. And so we make this PFO bubble above the fovea, as Al McGuire has suggested, to try to tamponade it, but it's not 100%. So with every surgery, there's this go for the gold, be safe kind of dichotomy, and I think over time, we'll learn more and more about that. Finally, the most important thing that I've learned is that it's just great to be part of a clinical trial that treats a type of blindness that during my training was thought to be untreatable and thought would be untreatable forever. It's the kind of work that we all dream of doing when we go into medicine, so it's a real pleasure to be able to get to do it. And Jean Bennett's science and perseverance has really propelled this technique forward. She's very deserving of the ARVO Alcon keynote address today, and I thank her for including me. This picture was taken at the very beginning of our Iowa CHOP collaboration, and this is Jean and Fraser Wright and myself and Steve Russell, our retina surgeon. We were at a Celtics game, and you have to do a lot to get on the Jumbotron at a Celtics game, and I told this little group I wanted to be on that Jumbotron, and we worked together, and we made it on the Jumbotron. I won't tell you what we had to do, but I'll just say I knew then it was going to be a great collaboration, and it has proved to be that way. Thank you.